In this video, I'm going to discuss how to rehab acute and chronic groin pain associated with your hip flexors. Anatomy and function. There are many muscles that have a role in flexing the hip, such as the tensor fasciae lata, sartorius, pectineus, adductor longus, and adductor brevis. However, today's video is focusing on the rectus femoris, iliacus, and psoas major. Although the rectus femoris has actions distally at the knee, and the psoas major functions proximally at the lumbar spine, the emphasis will be placed on their common action of hip flexion. Diagnosis. Groin pain in athletes is often classified based on the work of Ware et al. In 2015, Griffin et al. In 2016, and Thorborg et al. In 2018. Assuming that symptoms are unrelated to the lumbar spine, sacroiliac joint, or some other non-hip related condition, you might fall into one of 5 general categories: adductor-related groin pain, iliopsoas-related groin pain, inguinal-related groin pain, pubic-related groin pain, and hip-related groin pain, which includes anything that involves the hip joint itself, such as osteoarthritis, labral tears, and femoroacetabular impingement syndrome. Hip-related groin pain is quite common in the sporting population, according to studies by Bradshaw and colleagues in 2008 and Rankin and Bleakley in 2015. According to a systematic review by Raymond et al. In 2015, this category is less likely if you don't report symptoms with combined hip flexion, adduction, and internal rotation. It may also be less likely if you do not have limited hip internal rotation when your hip is flexed, and don't report catching, locking, clicking, or giving way. Let's cross that one off the list for now. Pubic-related groin pain is related to local tenderness of the pubic symphysis. Inguinal-related groin pain is related to pain in the inguinal region reproduced with resisted abdominal muscle testing, Valsalva maneuver, coughing, and or sneezing. It's also important that no palpable inguinal hernia is present. That leaves us with the last 2 categories: adductor-related groin pain and iliopsoas-related groin pain. According to studies by Helmick in 2007 and Cerner et al. In 2015, acute and chronic groin pain is more often related to the adductors than the hip flexors, although it's possible to have overlapping clinical entities. Adductor-related groin pain is associated with symptoms reproduced with palpation of the adductor longus, resisted adduction, and or stretching of the adductors. This finally brings us to the iliopsoas-related groin pain. This is diagnosed when there is pain in the anterior part of the proximal thigh, iliopsoas tenderness, and pain reproduced with resisted hip flexion and or hip flexor stretching. However, there are multiple hip flexors, so it's important to consider the location of symptoms and mechanism of injury in acute scenarios. Cerner et al. In 2018 state the following: only the iliacus or psoas major were injured in athletes reporting injury during change of direction, whereas rectus femoris injuries occurred primarily during kicking and sprinting. Therefore, the rectus femoris or iliopsoas may be involved depending on how the injury occurred. Even the portion of the rectus femoris involved depends on the mechanism of injury. One other thing to note is that the iliopsoas may more likely be involved in runners with long-standing groin pain, according to Helmick in 2007. Load management and activity modifications. Regardless if the injury is acute or chronic, iliopsoas or rectus femoris related, the first thing you want to do is modify aggravating activities. Whether the injury occurred during running, playing sports, or doing some other activity altogether, you'll want to manipulate the frequency, intensity, and volume of the given activity so that you can perform it in a tolerable manner. In some cases, this might involve discontinuing the activity for a certain period of time before gradually reintroducing it and ramping back up slowly. This is especially true of sprinting or max effort kicking as the demand on the hip flexors increases. Exercise progressions. The exercise progressions are pretty straightforward. There is one paper on the topic by Thorborg et al. In 2016 that demonstrated a 17% increase in isometric hip flexion strength following a 6-week training program performed for 10 minutes, 3 times per week in healthy participants. The subjects performed standing hip flexion with a band tied around their thigh while holding onto an object for support. On week 1, the subjects performed 3 sets of their 15 rep max, 3 times per week. Weeks 2 through 4 consisted of 3 sets of their 10 rep max, 3 times per week. Weeks 5 to 6 consisted of 3 sets of their 8 rep max, 3 times per week. Each rep consisted of a 3-second concentric, 2-second pause, 3-second eccentric, and 2-second rest. 2-minute rests were given between sets. To make the exercise easier, you can use a lighter band or not use a band at all. You can also shorten the range of motion into extension or flexion if it's not tolerable. Similar movements can be done with ankle weights, mini loop bands, or light kettlebells in standing. You want to maintain an upright trunk, squeeze your glutes and quads of the standing leg to keep a stable base, and lift that opposite leg so it's parallel to the ground or higher. Stand on an elevated surface to maximize the range of motion. A cable column is also a great option because the resistance is constant throughout the range of motion. Similar exercises can be done in supine or sideline on a table or bed. Hold the opposite hip into flexion to maximize the load on the hip flexors in a lengthened position. There's no shortage of options and no magical exercise. The goal would be to spend 6 to 12 weeks increasing the strength of your hip flexors through as large of a range of motion as possible by doing 3 to 4 sets of 8 to 15 reps 3 times per week. If you're not currently doing so, there might be an added benefit in training other aspects of your lower body and trunk by incorporating exercises that target your calves, hamstrings, quads, glutes, and core. In summary, hip flexor-related pain is considered when there is pain with palpation of the hip flexors, pain with resisted hip flexion, and pain with stretching of the hip flexors. The proximal rectus femoris may be more likely if kicking was involved, whereas the iliopsoas may be more likely if change of direction or running was involved. Although clinical entities can overlap, it's important to determine if it's a primary or secondary issue by considering other diagnoses. Rehab should consist of modifying aggravating activities while incorporating hip flexor-specific exercises as needed. Depending on your goals and training history, it may also be helpful to train other aspects of your legs and trunk. Thank you so much for watching. If you enjoyed the video, please hit that like button, subscribe, turn on notifications, and leave any questions or comments down below. Peace.